Just for anyone who hasn't met me, my name is Amer. I am part of the International EM and Global Health Division. I finished my fellowship here at County and Downstate in June. And today we want to do something a little bit different. We want to start the first of our workshop series on decolonizing emergency medicine and global health. So I'm going to walk you through the outline for today, and then we're going to get into the meat of the matter, right? So we're going to start with some introductory thoughts, some definitions so that we can lay the groundwork for the talk, a little bit of history about the relationship between colonialism and global health and how that fits into the context of our practice today. Then we're going to kind of break up into small groups and talk about how the relationship is relevant today to our current practice. And then we're going to come back and I'm going to wrap it up by why this matters to us specifically so that we can prepare for the next step moving forward. Just some general, thoughts that I had, while I was making this is, anytime we do anything, bias related type stuff, where we have to do any self-introspection, there's always going to be some challenges, right? Because this is not like a scientific paper, N of this, p-value of that, where everyone can just tease it apart and we can all reach a consensus within 5 minutes. A lot of this has to do with our personal thoughts and feelings. So obviously one of the things that we have to consider is there's always an element of defensiveness, right? Like people don't want to admit their biases that they might have. We're familiar with some biases, right? Like confirmation bias, implicit bias. There's also something called affinity bias, which is basically I prefer those who are like me versus those who are not like me. So I prefer to do things with those who are like me, make projects with those who are like me. Moral licensing, right? Or moral self-licensing. Basically, I feel that my education, my background, my experience makes me more of an authority on something than others. So it gives me more credibility than others. The other aspect is futility, right? So some people can feel like the problem is so big that like, what's the point of addressing it? What's the point of talking about it, right? If you get past those things, then there's an element of uncertainty, right? Okay, so now where do I start, right? How do I talk about this? How do I change all these things that I'm seeing or that I'm hearing about, right? And then obviously shadowing all of this is just an element of a little bit of social awkwardness, right? Because you have to kind of think about what you're feeling towards this subject before you can start to address it, because it's not a totally objective matter, right? And just to make it a little light, I'm going to have a little bit of medical trivia during the talk so that people don't fall asleep. Can anyone tell me what this instrument is called? And don't say forceps. I want to know what type of forceps it is or who it's named after.
DeBakey.
DeBakey, yes, correct. Can anyone tell me anything about DeBakey? Great. So you all got the first part of the question right? I'm going to give you the fun fact. So this is the guy that invented it, right? Dr. Michael DeBakey, right? You might know that he was one of the people to first successfully perform a carotid endarterectomy, a coronary bypass, multiple organ transplant, blah, 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 right? He's a cardiovascular and surgery legend, basically. What you might not know is he was actually born Michel Dabari to Lebanese immigrants. His name was later anglicized to Michael DeBakey, right? So just to know that like certain elements of our medical terminology have origins that might surprise you sometimes, right? So when you dig a little deeper, you might find something interesting. This is a quote from one of the letters that he wrote to Nixon, basically saying that because of the field of medicine has been generally recognized and accepted as an ennobling and genuinely humanitarian field of endeavor, it constitutes one of the strongest bridges across international borders, right? And the current pandemic that we're living through is kind of a prime example of how something like this can be a bridge or, at times points of contention as well. Let's move on to some, just definitions so we can lay the groundwork for this talk. So first, we're going to start asking ourselves, like, what do we mean by global health, right? Global health doesn't exactly mean that you have to go abroad to practice it, right? It also doesn't mean that you have to practice it within the confines of a government or an NGO or an organization like the WHO or anything like that, right? We actually practice global health in the ED here at county and in downstate every day, right? There's a term called GLOCAL, which is basically global health work in a local environment, right? So GLOCAL work. Every time you interact with a patient who has a different background, right? A patient who wasn't born in the US, a patient who doesn't live in America full time, right? Which I say about 20% of our patient population doesn't live in the US full time, right? They're visiting their family members or they're spending their 3 months here out of the year. You're practicing global health, right? If you volunteer at the asylum clinic, you're practicing global health. All of these things tie into our specialty. I'm sorry, let me just close the window because construction is happening and I don't want it to. New York City ambient sounds. So keeping all that in mind, right, then it's upon us to recognize that it's a privilege to be able to interact with these patients and to care for them. And hence it comes with the responsibility to practice with a level of empathy and compassion, right? Because we're always treating the whole patient. We're not just treating one of the patient's problems, right? So hence, that's why we need to understand what it is we're talking about before we can start to actually address it, right? Just some basic textbook definitions, right? Of like, what is colonialism, right? We're not going to go over this, right? Just so you have an idea. What is decolonization, right? And what I want you to pay attention to here is that the way that the definition is described kind of takes away some of the agency from the person who's doing the decolonizing, right? It's the action or process of a state withdrawing from a former colony, leaving it independent, as if I just left it to be, right? Obviously, what this neglects to say is that a lot of times decolonization is a rather violent process where people are pushed out and certain ideas are forced out rather than just kind of left on their own or, kind of melting away. Obviously, for us, the idea is that you have to think that every time you try to unpack any of the ideas or thoughts or notions that we have or we've been practicing in the medical field, you might face some resistance. And that resistance is not necessarily that what you're doing is wrong. It just might be that the system and the way that it's set up works in a certain way. And people have been doing things for so long that it just makes you the odd one out, right? But luckily, I think that we have one of the wokest emergency departments in the country, so that should be easier for us to kind of have these conversations together. So just some brief history and context of colonization when it comes to global health, right? And just so you all know, like in terms of global health, emergency medicine physicians are one of the most involved and active in global health today, right? Like there's us, there's obviously OBGYN, there's our neighbors in the peds ED, they do a lot of global health work, obviously all types of surgeons, but we are heavy, our presence is heavy on the ground. So therefore it's important for us to understand so that we know if we ever end up doing any work, how this relates to us. So these are just kind of some general ideas. This is obviously not a like textbook defined field, right? But you kind of have some loose definitions that, global health 1.0 was tropical medicine, right? Keeping wild men alive in the tropics. Basically, Europeans went to places where they never went before. They started catching diseases that they never caught before. So they started caring about those diseases. Global Health 2.0 is what's referred to as international health. So it's clever people in rich countries doing something to help people in poor countries, right? Let's give these countries our vaccines that we all came up with, that we tested over there, right? Global Health 3.0, which some people argue is the current state, is researchers from rich countries leading research programs in poor countries, right? We still see some of this happening today, right? Like there's a lot of NIH Fogarty grants that go to researchers here that then drive research in lower and middle income countries. The hope for the future is to attain Global Health 4.0, right? And that's basically research and all types of other activities being led by researchers from lower and middle income countries. Because right now we basically know that 80% of the health burden is in low and middle income countries, but only 20% of the researchers who are actually studying it. And I want to thank Dr. Mona Lisa Muchatuta for giving me this graphic, which she gave during one of her SAEM talks. Basically, just kind of list these things together so that you have an idea of like the progression and how this went, and the references I can give to anyone at the end. So from here, I want us to kind of move on to the small group discussion of our workshop focus, right? Before we do that, I want you all to keep in mind that all of these dynamic factors that are at play, at the center of those is always the asymmetry in power and privilege that we're going to continue to see during our lecture and workshop series, as we progress. So all of it kind of ties into the elephant in the room, which we can never lose sight of. And with that, I'm going to ask Dr. Warshaw to break us up into some small groups. And I want you all to start thinking about how is this relationship relevant today, and do you see it in your current practice? And then we'll come back and then we'll wrap up in the last 5 minutes. Everyone's small groups were fun. So we had some good luck with the first trivia. I'm going to try another piece of medical trivia. Can anyone tell me what this is?
Hibiscus.
It's hibiscus.
Hibiscus. Nice. All right. Does anyone know what hibiscus is used for besides drinking it? All right. So since this is a scientific conference, I put the scientific name up there on it, but we don't care about that, right? Hibiscus is a flower, right? It originated in North Africa and Southeast Asia. I actually grew up drinking hibiscus because part of my family is from Upper Egypt, which is in the south. But now it's found in tropical and subtropical climates, right? It's a herbal tea, can be drank hot or cold. It's called different things in different parts of the world. So like the top left, that little box is what you might see here mostly, because we have a mostly Caribbean population, and a lot of people from Jamaica drink hibiscus and from the islands. In the Arab world, you might see it known as karkade, which is in the bottom right. And that's how I grew up knowing it, right? It's actually used by some cultures to lower body temperature, right? Because you can imagine the heat, right? It's also used to lower blood pressure by some cultures. So there have been patients that when I came to county, I was surprised that when they told me that they use hibiscus for their blood pressure instead of their amlodipine, right? And it's just something to be aware of, because it's something that might not make sense to you to ask about, right? But it is something that's important to know, that certain things are traditional, and it's not, fake science. Like there's actually studies that have been done on this that have shown some indication that it can be used. It has a mild to moderate effect in lowering systolic blood pressure. The data is still not solid on whether or not it can lower blood sugar and cholesterol. But just to let you know that there are some patients that you might encounter that are using certain herbal remedies as a substitute. So it's always important to incorporate that question into your HPIs. Like when you ask the patient something, don't just ask them, what are you using or what are you taking? Just ask them if there's anything that they're relying on to control their chronic diseases, or if there's anything that they're drinking, and they'll usually volunteer that information to you if they don't feel like they're going to get judged on it. So the final point, right, is why does this matter to us here at county, right? We're in a unique position because we are, as the whole world has seen, we're on the front line, right? We're often the first point of contact with the healthcare system. And for many of our immigrant patients, we're sometimes the only point, because we're the only ones who can actually help them bridge the gap between what they're used to and how the system works here, right? And we're the ones who can connect them to all the things that they need to be connected to. At the same time, we have been kind of taught and socialized that the way that we are practicing is the status quo. But as we just saw, like no one is immune from biases, which means that it's on us to realize the impact of the interactions that we have with our patients and how much power that carries. Because with that, we can do more to change their lives. And with that, we can do more to improve our specialty and to improve the imprint that our specialty has, both within the Brooklyn ecosystem and then within the global environment. And I would like to thank you all for participating in this today. Stay tuned for part 2 with Dr. Karpov in a couple of months. And please send us your feedbacks and suggestions, any questions that you want us to incorporate in the next ones. And hopefully it was helpful.